Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or their guests are their own. Enjoy the show. Welcome to MS&Me Interviews. I am your host, Erica Lyons Richardson. This is our annual ACTRIMS review where we take a look at highlights from research presented at the ACTRIMS Forum from a patient's perspective. The 4th Annual America's Committee for Treatment and Research in Multiple Sclerosis Forum 2019 was held February 28th through March the 2nd in Dallas, Texas. Themed Precision Medicine Approaches for MS, Scientific Principles to Clinical Application, the CME accredited meeting stood apart from many traditional medical meetings by offering a singular track of scientific and clinical presentations in an interactive environment as well as numerous networking opportunities. Highlights of the forum included the Kenneth P. Johnson Memorial Lecture and the National MS Society Barancik Award presentation and talk. In addition, 2 poster sessions showcased approximately 200 posters. ACTRIMS is committed to fostering the careers of young investigators with an interest in MS. The first session of the forum was composed of platform presentations by young investigators who were selected based on a review of the submitted abstracts. In addition, junior faculty, fellows, and students who submitted abstracts were eligible for an education grant to support their attendance. Neurologists in training learned about career paths in clinical and investigative neuroimmunology through a pre-conference event called Neurology Resident Summit in Multiple Sclerosis. ACTRIMS Forum 2019 provided an excellent opportunity to interact with scientists and clinicians at cutting edge of MS research. The inaugural ACTRIMS Forum, held in New Orleans back in February of 2016, was a great success with over 600 participants, well surpassing the original projected attendance of 250, but year after year, the ACTRIMS Forum continues to be record-breaking participation with nearly 1,000 attendees in 2018. MS&Me Media Team had an amazing time serving as press in 2018 in San Diego. ACTRIMS continues to further its mission of providing leadership in the field of multiple sclerosis and other demyelinating diseases. Now, the goals of this year's forum were discuss precision medicine approaches for MS diagnosis and management, review current knowledge of biomarkers differentiating different forms of MS and MS from other disorders, other demyelinating disorders, understand clinical, biological, and radiological predictors of MS disease course, examine emerging biotechnologies applicable to MS, discuss the algorithms and predictive models for MS management, provide mentorship to trainees and junior faculty interested in a career in MS research and or clinical practice, ensure that research findings are disseminated to various stakeholder groups including MS care providers, researchers, the media outlets, social media, and patient advocacy groups. Now, let's look at some of the top MS research and clinical news presented at the ACTRIMS 2019 Forum from our patient perspective. And it will really be from a patient perspective this year because I'm in the middle of a MS relapse, and you will hear the slurred words. You will hear me have word choice issues. So this will definitely be something that you can follow along with. Okay, let's get started. Now, one of the most exciting subjects that was discussed at the forum this year was neurofilament light protein, or NFL for short. That's what we'll call it. Be much easier to follow along if we just call it NFL in predicting disease activity and treatment response. So mounting evidence on the reliability of blood-derived neurofilament light protein, NFL, in predicting disease activity and treatment response in MS is raising hope among MS experts about its utility as an invaluable and easily accessible tool in the near future. NFL, when derived from cerebral spinal fluid, has already been validated as representing a highly specific marker of neurodamage and longitudinal predictor of the course of the disease. However, the need to perform a lumbar puncture hinders its use as a routine tool in the clinical practice. But advances in the development of high sensitivity assays such as the single molecule array, let's just call it SAMOA, are allowing for key biomarkers such as NFL to make a critical transition from CSF to blood-based measures. Dr. David Leppert, Senior Researcher Associate at the Department of Neurology at University Hospital Basel, Switzerland, stated in an interview at ACTRIMS, "We already are at the point of being able to use peripheral serum-based NFL on a group level. We are still not at the individual level yet, patient-based, but I am very positive that we have a breakthrough in the next 2 to 3 years for individual use of NFL." Among research helping to push the field closer to the goal by validating the prognostic efficacy of serum NFL is a study published online March the 5th in Neurology, in which Dr. Leppert and his colleagues evaluated data on NFL in the blood samples of 589 patients with relapsing remitting MS. The patients were participants in 2 phase 3 clinical trials, the 2-year FREEDOMS trial evaluating MS drug fingolimod versus a placebo, and a 1-year active control TRANSFORM trial evaluating interferon beta 1A, the higher NFL levels seen even in patients without enhancing lesions compared with healthy controls underscore the potential importance of NFL as a biomarker of disease changes that may otherwise be elusive with MRI, the authors said. This finding suggests that NFL also is reflective of ongoing neuronal damage and loss of independent detectable inflammatory activity possibly occurring in normal appearing gray and white matter. Leppert and his colleagues wrote in this report. This assumption is further supported by the correlation between NFL levels and an objective measure of neuraxonal damage, brain and spinal cord volume loss, and a recent study by his group. Okay, so they use the baseline in that for volume loss at 2 years on the study in the FREEDOMS trial. Together, these results suggest that NFL in the blood is likely to reflect an integral measure of recent and ongoing neuronal damage over weeks and possibly months. So in his talk, Dr. Leppert noted other studies, including the EXPAND trial, which showed as many as 46% of patients with secondary progressive MS had higher NFL levels despite no lesions on the MRI, and the INFORMS trial, in which 18% of patients with PPMS had primary progressive MS had no apparent lesions. So, while blood-derived NFL has advantages over CFL-derived measures, there are also benefits in comparison with the MRI. The current standard, of course, for the brain atrophy in MS, and then importantly, MRI is by nature retrospectively, of course, costly and as such not ideal for longitudinal monitoring of the disease, either in clinical trials or routine practice. So, Dr. Leppert said that MRI is the measuring of a structural deficit of the past, while NFL is measuring in real time what axonal damage is occurring and leads to a more comprehensive report. So, among the key gaps in the evidence that remain to be better understood before the blood marker, NFL can go mainstream in individual treatment is the need for more prospective studies that correlate with MRI and better validation and optimization of the assay. Okay, so in a separate talk at the meeting, a friend to MS&Me, Dr. Gavin Giovannoni, professor of neurology at Blizzard Institute, Queen Mary, University of London, United Kingdom, underscored the potentially powerful role that serum NFL could play in MS. He stated, "I think our C-reactive protein is coming, and it's going to be in the form of peripheral blood NFL," he said. So he is saying that in reference to an editorial that he had published in the issue of the journal Brain in 2018 titled "Peripheral Blood NFL Levels, the Neurologist C-Reactive Protein." All right. Now, Giovannoni said that he has already seen important benefits with CSF NFL, I got to write that down, in routine clinical practice. It's going to be a great biomarker to have in clinical practice. We are already using CSF-derived NFL levels in our center, and it's amazing when you start getting NFL results on your desktop. He said it affects how you decision make, all right? He described an example of how NFL was used at his center in a case that involved a female patient with active MS who strongly believed she was experiencing a flare-up but showed no clinical evidence of a relapse or new lesions on MRI of the brain and spinal cord, which is quite common, as you know, with many of us. A lumbar puncture showed her CSF-derived NFL levels to be as much as 3 times higher than normal, and she was subsequently switched to a different therapy. So they switched her DMD even though she had nothing show up on her MRI, which most likely would not have happened otherwise in clinical practice. Without that patient's NFL measures, the outcome would have been much different, as Dr. Giovannoni stated. Without the result, this patient would have been told this was a pseudo or minor relapse and given no treatment. That was Dr. Giovannoni. He stated, in fact, this triggered a reassessment of her clinical state and change in her treatment. He added that the case underscores that NFL might be a great way of determining a true relapse from a pseudo-relapse, and on the football pitch of minor head injury from a moderate to a head injury. Okay? Giovannoni noted that as a prognostic and treatment response marker, NFL really separates the men from the boys in reference to the effects of the high-efficacy disease-modifying therapies in reducing NFL levels compared to lower-efficacy treatments. He said that he suspects we will soon be ordering blood NFL levels several times a year and maybe even more frequently to monitor MS activity. In such cases, the treatment target will be to normalize NFL levels and keep the area under the curve as low as possible. Dr. Giovannoni said that even in those cases, the measure would not necessarily be used in isolation, but conjunction with other factors. So there would still be other monitoring. And now on to our next topic, the new consensus statement on MS imaging strategies. This piggybacks off of our last subject. Although there are currently several promising techniques for imaging biomarkers of the neuroprotection and repair in multiple sclerosis, deciding which one to use depends on a number of factors. A new consensus statement suggested at the ACTRIMS forum. During a November 2016 North American Imaging MS Cooperative Workshop meeting, a group of experts in the use of MRI for patients with MS discussed both current and the emerging imaging techniques in the field. This led to a recent release of a consensus opinion on each strategy for members of the NAMES Cooperative. Now, the two MRI biomarkers can potentially distinguish RIS from other disorders. IRS is, of course, radiologically isolated syndrome. Two new magnetic resonance imaging biomarkers called central vein sign and paramagnetic rim sign could be used for differentiating true radiologically isolated syndrome, in other words, something only seen on an MRI but no other signs of disease activity, those patients from those with mimicking features, the new MS research shows. The findings were presented at the ACTRIMS 2019 forum as part of the NAME Symposium, The Central Vein Sign in Multiple Sclerosis, Update and Future Directions. March 1st presentation was titled The Central Vein Paramagnetic Rim Sign and RIS Syndrome. It was given by Dr. Suradek, let me say this in the last name, during a relapse. Here we go, I want to do it justice. Satapalth Sawan from St. Michael's Hospital in the University of Toronto in Canada. The area surrounding the brain's central vessels, called the perivernacular space, is thought to be a site where an inflammatory cascade is likely triggered, lending itself to the formation of lesions around these veins that can be readily observed using an MRI. Although highly suggestive of MS, RIS is a disorder describing asymptomatic individuals with incidental radiologic abnormalities detected by the MRI. These abnormalities can present in the perivernacular space as in MS. Now, according to the doctor, 1/3 of RIS patients develop definitive MS within 5 years. Okay, they have that abnormality show up on the MRI in the perivenular space, and then within 5 years, they develop definitive MS. Because of the high similarities in radiologic presentation, yet different health outcomes, there is a need to develop test markers that are able to distinguish RIS, okay, from MS. MRI studies aiming to identify MS biomarkers have demonstrated that many white matter lesions in MS patients have a visible MRI signal in the central vein, a central vein sign. These studies also have shown that some chronic MS lesions have a unique signal called the paramagnetic rim sign. This signal at the rim of the lesion may represent chronic active inflammation. Although both central vein signs and paramagnetic rim signs have been observed in MS patients, they have yet to be assessed in RIS patients. Thus, the researchers from St. Michael's Hospital at University of Toronto evaluated the presence of these potential distinguishing MRI markers in white matter lesions of the RIS patients. The researchers examined 50 people with RIS between July 2017 and July 2018 who underwent MRI to assess white matter lesions for central vein signs and paramagnetic rim signs. The results showed that every RIS participant had white matter lesions that were positive for the central vein sign. The average proportion of white matter lesions positive for the central vein sign per case was about 4 out of 5 lesions, so 83%. A strong correlation was found between the proportion of central vein signs and the paramagnetic rim signs in the white matter RIS patients. Now, RIS cases without paramagnetic rim signs had low proportions of positive central vein signs in white matter lesions. Overall, most RIS cases had a large proportion of central vein signal positive white matter lesions, indicating that the perivenular pathology, the majority of the RIS cases had more than 40% central vein sign positive white matter lesions per case. Now, the doctor added that this result meets the 40% threshold that's been proposed to distinguish MS from non-MS. A large, though smaller type proportion of RIS cases also had a paramagnetic rim sign positive white matter lesions. Now, these findings suggest that the majority of RIS subjects harbor both the perivenular inflammation, the subclinical chronic active demyelinating demyelinating, similar to MS. Now, this suggests that RIS patients may be at risk of eventually developing progressive clinical symptoms. Based on the results, the team suggested that both central vein sign and the paramagnetic rim sign could potentially be useful to differentiate between true RIS and from mimickers. The researchers have planned a follow-up study to this patient cohort. All right, so it will give us better understanding. And as most of you know who have went through long diagnosis processes, had inconclusive test results, any of these tests that we can find a more exact solution to cut down the time until definitive diagnosis is a definite positive step for the patients living with MS. Now, another subject that was discussed at the forum was spinal cord atrophy is greater in secondary progressive MS. Atrophy in the spinal cord imaged on brain MRI shows significantly faster acceleration in MS patients who advanced to secondary progressive disease compared with those who remain in relapsing remitting MS, with differences between the two emerging as far as 4 years prior to disease progression, the new research showed. Now, the study co-author Dr. Ante Bischoff from Basel University Hospital in Basel, Switzerland, stated, "We show for the first time that spinal cord atrophy rates are faster in relapsing remitting MS patients who later converted to secondary progressive disease compared to a matched group of patients who remained relapsing remitting over 2 decades. Our results show in this study," he stated, "that cervical cord atrophy rate at C1 level as a prognostic biomarker for the conversion to secondary progressive MS and could be useful for treatment decisions early in the disease course, and for the study of genetic epidemiology," I didn't say that right, epidemiologic and immune variable in MS. Now, the research was presented at the ACTRIMS forum, and with MRI revealing an ever-expanding array of invaluable insights into how MS manifests itself, the strongest correlations with disability have been observed in the spinal cord. To more closely investigate the role of spinal cord atrophy in impending conversion from RRMS to the more advanced stages of MS, Bischoff and her colleagues enrolled 54 subjects who had converted to secondary progressive MS and compared them with 54 age-matched, sex-matched, and disease duration matched RRMS patients who did not progress over the study's 12-year observation period. An additional 54 age-matched and sex-matched healthy controls were also evaluated with MRI study. Overall, participants had a mean age of about 47. The analysis of brain volume metrics and spinal cord area C1 showed that those who advanced to secondary progressive MS, there was a significantly higher rate of spinal cord atrophy prior to their conversion compared to their matched RRMS patients who did not convert to secondary progressive MS over the same period. Furthermore, the differences between the groups were seen beginning as far as 4 years prior to the conversion to secondary progressive MS, with a little overlap between the two groups. baseline brain volumes, while lower in MS patients compared with healthy controls were not significantly different between those with RRMS patients and those who progressed to the secondary disease. Interestingly, the study showed no other significant differences between those who did and did not convert from RRMS to secondary progressive MS in terms of the T1, T2 lesion volumes or regional and global brain volumes at baseline and over the 12 years of the study. The observation of the differences up to 4 years prior to the conversion was particularly notable. It was indeed surprising to see the rapid cord atrophy rates up to 4 years before the conversion to the secondary progressive disease, the doctor stated. This indicates that those patients who were later converted likely have more severe spinal cord volume loss already early in the disease course when compared to those relapsing remitting patients who remain relapsing for more than 2 decades since the disease onset. In addition to helping the assessment of the long-term impact of treatment in clinical trials as well as legacy data sets, the findings could have important clinical implications in terms of allowing for an early stratification of a patient at risk for severe disability, providing guidance of individualized treatment decisions, for that patient. Moving ahead, key questions that remain to be answered are: what are the exact mechanisms that lead to the spinal cord atrophy? Currently, there is a lack of understanding of the factors that drive the neurodegenerative process, including the destruction of the axons and neuronal loss in the spinal cord. It remains unclear whether the process occurs as an independent primary process or rather as a secondary autoimmune mediated inflammatory process in the spine. The study offers insight that could be valuable on a variety of levels. One of the most interesting findings was that the spinal cord diameter is actually smaller in the patients who are going to transition to progressive MS before the clinical transition takes place. So this could be a prognostic marker of patients who are going to accumulate disability in the future. This could be very valuable in terms of clinical trial design, as well as how they personalize clinical trials and ultimately treatments if you can enrich your studies with a subset of patients who have relapsing or remitting MS but are likely to enter the progressive phase. So Siegel, who was not associated with the current study, added that the findings are notable for being novel. There's a lot of literature showing a correlation between spinal cord atrophy and disability, but the finding that the spinal cord diameter can be a predictor of the transition to progressive phase is novel and very important. So we'll go ahead and stop here and then continue our review next week in part 2 of our ACTRIMS review. Thank you so much for joining me again here on MS&Me interviews. Please join me again next week, and if you have any questions, please visit us at msmemedia.com.